9 out of 10 patients, they'll come in saying, I don't like this. And like you said, as the teeth are straightening, they spend so long looking at their teeth, they'll find other things they don't like. So it's just always worth gathering this information at the beginning, as much as you can, so you can exceed the expectations rather than under-deliver.
Do you remember when you had to learn a new skill? Maybe in dentistry, you were learning a new technique, a new procedure. Maybe you were learning orthodontics. What were the things that you were most worried about back when you were starting out? Or maybe you're thinking about going into orthodontics. What is it that worries you? For me, at the beginning, I have to say IPR was a tricky subject because it's not really the theory, because the theory makes sense. You create some space, you move some teeth, the theory is all fine. And we know evidence-based suggests it's pretty safe if done well. And we'll talk about that in this episode. But it's more about the how to and how not to do it wrong. Because once you've seen the photos of when it has been done badly, then that sort of haunts you. So when you're there doing your IPR, you're sort of underdoing it at the beginning. You're not creating enough space, and therefore you're not meeting your treatment objectives as fast enough. Or if you're, God forbid, removing it overzealously, or your technique is such that it's leaving your teeth in a slightly suboptimal morphology. So these are all the considerations I was having when I was starting out IPR. So then I consulted some mentors, my principal, who was very helpful in helping me to do the right techniques using the burr. My principal taught me how to use a burr, and I'm very thankful for that. It can be a topic that can be of concern for some people because we all want to do a fantastic job for our patients, and we all want to do it safely and effectively. So this episode will hopefully cover a lot of the nuances of interproximal reduction for orthodontics, and I hope it helps. I'm joined by Dr. Devaki Patel, who is a specialist orthodontist, and she's going to be showing us a few diagrams, a few of the strips that she uses, and how to use all these sorts of tools, when to use them, when not to use them, because it is very much case dependent. Every case will come at you with its unique challenges, and therefore you have to adapt your techniques to be specific to that patient you're treating. The protrusive dental pearl I have for you is an orthodontic one, because the chances are, if you're watching or listening to this, then maybe you've already started to dabble in orthodontics. Maybe you do a fair bit of orthodontics already, so it's only right that I make the pearl an orthodontic one. And chances are that nowadays you may be using a clear aligner system of some description. Now, some of these clear aligner systems have got their softwares which they can emulate a virtual teeth, if you like. So some companies may call it a ClinCheck. When you're looking at your ClinCheck, the first thing that you need to do, and the pearl is basically the first thing you need to do, is check that the bite setup is correct. Because every now and then you get a ClinCheck back and you like the look of it, it's looking good, and you approve it. But you don't realize that actually right at the beginning, the technician who was setting up your case, either because they didn't have the correct information or the best quality information, i.e. the setup wasn't perfect for them, it wasn't easy for them, they've set the case up wrong, which means that the occlusion that you sent them is not quite what is actually happening in the patient's mouth. So my pearl for you is, if you're doing a clear align system with a ClinCheck type of software, the first thing to do when you get your case back from the technician is check the setup. Make sure the teeth are touching correctly as they are in your patient's mouth, because sometimes they do get it wrong, and I've spotted this before. And if they get it wrong, then your whole treatment plan from there will not be accurate. It will be completely arbitrary, because it may align the teeth to some degrees, but it will not match the arches up. So that's my protrusive pearl for you today. So let's join Dr. Devaki and learn all about IPR. Devaki, thank you so much for coming on the Protrusive Dental Podcast. How are you?
Yeah, I'm brilliant. Thank you so much, Jess, for having me. I'm so happy and excited to do this.
No, it's going to be a great topic. It's IPR. So this is all about IPR. And the reason I wanted to discuss about IPR is because, as I was saying to you earlier, sometimes when you've done something, like I've been doing orthodontics for a few years now, I've got a diploma in orthodontics, and obviously you're a specialist. We're going to come on to a little bit about your journey and stuff. But sometimes when you've been doing something a while, you almost forget, or you disengage yourself with the struggles that you had at the beginning. And for me, one of the struggles I had is like IPR, like how to orientate your burr, which strips to use, how to use them safely. And with being a minimally invasive dentist, you're almost like really worried about cocking it up.
Yeah, I completely agree. I mean, especially now we want to be conservative, especially with IPR and something like enamel, you can never get it back once you've taken it away. So it's something really important. You want to plan it properly, and if you fail to plan, you plan to fail. So
absolutely. And once you see photos, or once you actually see clinically some IPR that hasn't quite gone to plan, that's a really horrifying scene. So that's why I'm really, really happy to be covering IPR. So we're going to make this the most impactful content, hopefully audio and video, on interproximal reduction. I do think with some of my episodes, the video version may have better value, but obviously if you're driving or you're chopping your onions, you want to listen to something, then this is going to be hopefully useful to you still, because we'll discuss a little bit about the history and the evidence base and the sort of risks and stuff, but we'll cover A to Z, and we want to make it, like you said earlier, Devaki, we want to make it very clinically applicable.
Yeah, exactly. So it helps everyone.
Absolutely. So tell us a little bit about yourselves, Devaki.
Okay, so I'm a specialist orthodontist. I actually graduated my ortho training last year, so quite newly qualified in that. I did dentistry at Barts in the London and qualified in 2013. Then I did my foundation year, and I pretty much knew at undergrad that I wanted to do ortho. So everything after that was just ortho, I want to get in. And as you probably know, it's just jumping after one hoop after another. So after that, I did a year in Max Fax, and then I did a year in pediatric community dentistry.
You did the very standard classic route.
Standard classic route, exactly. Doing posters, publications, presenting, that sort of thing. Because I knew what I wanted to do, and there is a specification of how to do your application. I just followed that really closely. And then I applied for training. I got in and went back to the Royal London again for another 3 years. So yeah, really enjoyable, and I really love ortho. It's amazing job.
That definitely shows through in your social media channels, and that's why it's great to have you on, someone passionate about what they do, which is what this show is all about. Basically, I want to bring passionate people on with their respective topics. So yeah, it'll be great speaking to you about this. But one thing I do want to know, Devaki, is I used to joke, and please take this light. I used to joke before I did a diploma in orthodontics that and take this lightly. I said I used to say that if you don't like dentistry, do ortho.
Oh my gosh, that's not a joke.
No, but I realized no. You can know. Basically, I've since changed that view. Obviously, since I've started getting more involved in orthodontics. But it was just a little thing, because I find that if you don't want to fiddle around with a bit of gum and the matrix plan, that you want to work more with your mind.
Exactly. You know what? It's not even a joke. If you ask most orthodontists, not many of them really liked dentistry, and like you said, orthodontics is pretty much 90% just in your mind. It's planning, and then 10% actually doing. So it's very clean, and it is like that. It's just basically like a puzzle. You have to figure out.
Yeah, absolutely. And one thing I've appreciated more for you, specialists and anyone doing orthodontics, is that in restorative dentistry and even let's say occlusion and prosthodontics, there's so many conflicting views and opinions. Okay, but they've got nothing on the world of ortho. You guys, the ortho world, honestly, you guys have like some polar camps. Who you got the Damon lot, you got the MBT lot, you've got the orthotropics, orthopedic orthodontics, the people who tell you that if you remove premolars you're going to die because you won't get any oxygen anymore. So you've got real polar views in orthodontics. Yeah,
you've got extractionists, non-extractionists, Invisalign, lingual. Yeah, you've got so many different teams.
So that it sometimes gets confusing, but it also makes it very interesting.
It does, and you can choose the type of clinician you want to be and the way you want to practice. So it's great.
Awesome. Well, let's dive right in, as I say, to the first question about IPR. So the mission here is to help those starting out with IPR to do it safely, and even those who've done a fair bit of IPR, just to revise, are we doing it the best way? Could there be a more effective way? Because there are sometimes more challenging scenarios to approach. So let's start off by talking about the methods of IPR, or maybe we should talk about IPR from the beginning, as an IPR as an alternative to extraction, and what the evidence base is perhaps for IPR.
Yeah, of course. So IPR stands for Inter-proximal reduction. It's known under many different names. So it's also known as stripping, slenderization, polishing. There's so many different names for it. They all mean the same thing.
What do you say to your patient?
I actually call it interproximal stripping. I guess it's the way I was taught, but the way I say it to the patients is just like filing in between the teeth or polishing in between the teeth. Yeah, it's just much easier for them to understand. And actually, the way I would describe it to a patient is very different to a clinician. And it's a method of space creation, right? So if I see a case, and it is case dependent, that has mild crowding or early moderate, but mainly mild, and mild is anything up to 4 millimeters, I would want to go down the stripping route as a method to create space. It's not just a method to create space. You can use it for various other ways. For example, retracting your lower incisors if you've got particular class 3 tendency, so a bit of a reduced overjet. If you've got a Bolton's 2 size discrepancy, so you want to correct that. You've got a discrepancy.
Let's touch on that. For those listening right now who don't know what a TSD is, a Bolton's 2 size discrepancy, if you just briefly describe what that is, because actually from my orthodontic teaching that I've had is that sometimes if you use IPR inappropriately, you actually create a TSD.
Yeah, you're completely correct. Yeah, and that's why it's really worth mentioning it. So Bolton's 2 size discrepancy is basically you add up the mesio and distal widths of your anterior 6 teeth, or you can extend it to the posterior teeth. So there are 2 different types. And if there is a discrepancy of the sum of the mandibular widths to the maxillary widths, there is a figure. I think it's 91.3% for your what it should be. And if it's outside 2 standard deviations of that, then you've got a Bolton's 2 size discrepancy.
My professor who taught me had a really good analogy in a way to describe TSD. So tell me if you've heard of this one. It's like the foot and the shoe. So your shoe has to be just a little bit bigger than your foot, okay, for it to fit snugly and perfectly. But if either your foot is too small, or your shoe is too big, or your shoe is too small, and your foot is too big, vice versa, then that is a discrepancy. And so either if you got your maxillary teeth too big, or your mandibular teeth just and it could be various combinations, but it's not going to fit together. You're not going to get the right overjet.
Yeah, exactly. And that can present as, so if you've got too much tooth tissue in the top, you're going to have an increased overjet, for example. Too much tooth tissue in the bottom, you've got a reverse overjet. You're going into a class 3 kind of bite. And that's so important. I mean, one of the things you need to consider when you're aligning teeth is you don't want your lower teeth to procline. You don't want them to come forward. You want to maintain their position. It's so important for stability too. So that's why a bit of IPR can help maintain your lower incisor position as well. So yeah, there are 3 different ways you can do IPR. You can do it with a interdental strip, abrasive strip, or a diamond encrusted strip. You can also use a rotating disc, and you can also use a burr. So there are the 3 kind of main ways. And there have been a lot of more developments on those, for example, oscillating handpieces and that sort of thing. But they're predominantly the 3 different areas in which they're used.
Orthodontists have a lot of breadth of evidence on various things. Like I know there are some studies looking at the fact that but if you were to pre-stretch some elastic before you apply it, does it make a difference or not? And even like looking at the minutiae of details. So is there any evidence to suggest that one method of IPR is superior to another?
Most of the evidence is about the effect and stability of IPR. There isn't really, I haven't come across any studies comparing the different types of IPR. I think that is basically case dependent, and also how comfortable the user feels with using these methods as well. But there is plenty of evidence to suggest how much IPR is appropriate. For example, Sheridan in 2007 said 2.5 millimeters for the anterior 5 contacts, and I think it's 8.4 millimeters for the buccal 8 posterior contacts. It's an acceptable amount. And then there have been studies to show that anything more than 50% of the enamel thickness can be detrimental to the tooth in terms of developing decay and periodontal problems. So that's why anything less than 0.5 millimeters is deemed acceptable.
Is there any point? That's great. So take home message is if you're in and around 0.5 or less, you should be okay as a whole. Obviously, there are other tooth morphology issues we'll come on to later.
Exactly,
But
yeah.
but as a general rule of thumb, 0.5
Yeah.
and below is fine. Now, I once had a case where I had a lady who her main complaint was that she didn't like her upper central incisors. They were too big, and the width of her upper central incisors per tooth was around about 10.3, 10.5 millimeters each. So that's like mega denture category. So in that case, I actually for my ClinCheck for a liner case, I requested a bit more IPR than what I would normally do to help me overcome this issue. Is that an acceptable thing to do in certain cases?
Yeah, I think if you've got a tooth which is megadont, then that is acceptable. Obviously, it can be used to recontour teeth if they've got unusual morphology, and it's also optimizing aesthetics, right? So your central is an aesthetic zone. You want to give the patient the best result possible. But then you also have to consider the shape of the tooth. So McLaughlin and Bennett have described 3 different shapes of teeth. So you've got triangular teeth, rectangular teeth, or barrel-shaped teeth. And if you've got a parallel tooth, it's not really advised that you, what I mean by parallel is a rectangular shaped tooth. It's not really advised.
So maximal area of contact between the teeth.
Exactly. Yeah. IPR in those sort of teeth is not really advised. Whereas if your central is kind of triangular shaped, then you can afford to take away tooth tissue near the incisal contacts. So it would lend itself better.
You had a diagram, I believe, to show this.
Yeah, exactly. So excuse the poor drawing.
It's fantastic. It's way better than what I could do, honestly.
So here's an example of some lower incisors. These teeth are fan shaped, so triangular shaped. And here, this red area is where you would carry out IPR. And you can see that we've taken away a lot more tooth tissue incisally relative to the gingival area.
So the tooth on your right was the triangular one, whereas the one on your left is the rectangular one, yeah?
Exactly. So you can see how it affects the amount of enamel you take away.
Big time.
But then imagine that tooth tissue removed, then you've got parallel edges. You would then use that to relieve your crowding and then move the teeth together. But then I think it's also good to mention something to your patients, and also for us to know as well, is black triangles. Because obviously as we get older, we suffer bone loss and migration of the gingival tissue. We are going to have black triangles, and patients often notice it as the teeth align, because if you've got overlapped teeth and they align, you're going to start noticing these things. So that's another case where IPR can help if you have the fan-shaped teeth.
I'm a huge fan of using IPR to de-triangulate teeth and to get rid of black triangles. And it's a great thing to do. And a term that I actually learned from Tiff Fresh some years ago is PPR. So it's predictive proximal reduction, where you're doing it in advance, so that as the teeth move into the correct position, aligned position, that you've already accounted for that. So it's a great thing to plan in advance, so that you can actually remove the amount of enamel that you need to get a more rectangular appearance, and therefore get rid of a black triangle.
Yeah, exactly. And I mean, I never tell a patient that I'm completely going to get rid of this for you, because you never really know, and you don't want to take you don't really want to take away. If you have that fan shape, you can't take away the tooth tissue, which is further gingival, right? So I always say I can.
If you've got the parallel, I mean, if you've got the barrel shaped tooth, that's when it's difficult. Yeah,
that's when it's difficult. That's when I say I can't, because if they're parallel, you're just going to end up removing quite a bit of tooth tissue, and even to the extent where you could traumatize the gingiva. So,
and you're completely right. Communication with these patients. So don't overpromise, because it's not 100% predictable if you can get rid of them or not. You can say, I'm going to try, and this is what you maybe end up with, but I'll try my best, and let's see how your body responds. But the other thing is that you learn this early on, is that if you don't warn the patient about black triangles, then you're really fighting a battle. And the best way I find is that when I show them a photo of their crossed over tooth, I say that can you see that your teeth are squashing your gum? Your gum is squashed. So when your teeth become straight, your squashed gum unfortunately doesn't grow back. You're going to have a area where spinach will get stuck. Can you imagine what I'm saying? And they all go, yeah, I see what you mean.
Yeah, exactly. And it's nothing you're doing wrong. It's basically their anatomy. So if you explain, this is where your bone sits and this is where your teeth sit, and there's a void, and that presents itself as a triangle, they pretty much understand.
Mm-hmm. And as a restorative dentist, I'm happy and I like using the BioClear matrices to close these black triangles. So sometimes where it's where you see that it's going to be difficult to close fully, then you could tell the patient that, look, there may be some additional procedures you may require afterwards with composite or whatever to make sure we can get the full closure that we want. So it's often unrealistic to say that orthodontics alone will sort it, but obviously it's case dependent.
Yeah, it's case dependent, but I completely agree. You're right, and it's good to have that alternative option.
Brilliant. So now we touched on the 3 methods of IPR. Which do you prefer?
I personally prefer the abrasive, the diamond strips. Because,
can you show us which ones? Can you show the listeners?
Yeah, sure. Yeah. So I normally buy an assortment. So this is single-sided diamond, and the color is yellow. Here we go. This is the finest. It's extra fine. It's then followed by red, which is fine, and then blue, which is medium. So normally, I would always suggest if you're trying to carry out IPR, you go in first with the serrated metal strips, because that helps break the contact point. Then I would use a yellow diamond strip like this to go in and kind of see it, a bit like floss when you see it around the tooth, and go up and down, and then the other way. And then I would move on to the red and then the blue. And then you measure, it's always worth measuring how much you're taking away with a IPR gauge.
Mm-hmm.
So I think I got this from Henry Schein or...
I mean, I know a lot of orthodontists who have just been doing it for so long, and colleagues that they just eyeball it. I personally find that I'm much happier to use the gauge. It's very, very scientific. It's very proper. I like doing it. But have you got any tips? Because look, that gauge is you can't always use it. Now, it's a great opportunity for me to show you that case that we can discuss some difficulties you may have with IPR, and we can actually discuss this case. How would you plan the IPR? So let's do that. Okay, great. So this patient came in with crowded lower anteriors, main complaint. And there we are. I've been a good boy. I haven't done any more than 0.5 anywhere. So in that scenario, let's just pause that there. In that scenario, once you've removed some enamel, and here I might use something like a soft Lex disc, a coarse soft Lex disc, to just remove some material and a bit of the strips. I certainly wouldn't be using burrs in this case, because I think you're just contacting the gingival area. You're not actually doing anything higher up where you need to do it. Is there any, in this case, is there anything different you do? And also, in this instance, you may not be able to use your gauge, right?
You can still use the gauge. I find you can still use the gauge, because the way I do it, I don't do it all in one go. So I'll spread out my IPR, and especially when you're planning your clean check, you have to think of each stage as a different stage in its own right. So you plan, for example, we know that your lower left 2 and your lower right 1 need space, right? So you're going to have to do IPR adjacent. So that's where I would start off doing my IPR adjacent to those teeth, so that I could then bring them in. And I think you're completely right. I mean, you could even use something like a separator to be able to facilitate access for IPR, and then use the strips. And then I know a lot of my colleagues, they start with the strips, and then they will use something like a mechanical IPR system or the air rotor discs.
I think what I found useful in cases like these is to use a measuring device. I'm trying to think of it. It's a very normal measuring device. The tools. So in this case, I use like a digital caliper to measure beforehand, and then when I use my soft Lex disc, or maybe even a burr, very carefully under high magnification, just to remove that sort of the incisal part where it's a bit more triangular, and then measure it again. I find that sometimes in my hands can work better than using the IPR gauge, because I just find in between that lower left 2 and lower left 1, I might find it quite difficult. It might be like an angle. It might not be like especially after the first visit, completely sort of adjacent to the tooth?
Yeah, no, yeah, they can be tricky. You have to put them in a certain angle to get them down, because especially in between the laterals and the canines, canines are so bulbous, so you can have a really sometimes quite a tight contact point there.
And what are you hoping to feel with the IPR gauge? I mean, should there be because sometimes you try and put it in gently and it won't go through. But if you just put a little bit of force, it'll go all the way down. So my understanding is that however a floss should feel, so like, you have to do a little bit tight, the IPR gauge, it's okay to just force it a little bit. Whereas some people have said that actually there should be no resistance. You should be able to go all the way down. So which is the right way?
I could liken it to how floss feels when you're taking it through a contact point.
Mm-hmm.
But
so it just needs a little bit of a nudge.
Yeah, but not to the point where you're ramming it down. Then you haven't done enough.
Yep.
So normally I spread out my IPR. So I do about 0.2, for example, at a time. So if we look at these, I'll always start by getting the 0.1 in. And once I know I've got my 0.1 in, and the 0.1 is so thin, some people have this space between their teeth already.
Mm-hmm.
And then after that, I'll go 0.2. You can even get other ones where they have 0.15, 0.2, 0.25. That's how I would normally do it. I actually really like these. I think it works really nicely.
Mm-hmm, mm-hmm. So I think it's a really handy tool to use as well. Completely agree with you. So I'm just going to finish off this. Yep, go for it.
Okay, there's no space in there, but either you go through this way or you'll go through downwards.
And it should the same thing?
Slip in.
Yeah, either way, it should be the same.
Yeah, through the contact point.
Thank you for that. It's really handy to see. So just to go this case, so that's how the ClinCheck, obviously, ClinCheck is cartoonodontics. It's not real ortho, so always don't compare it to real life. It's just a guide. So anyway, we got this through one round of aligners. Okay alignment so far. We're just going to do some additional aligners to get the torque correct. And you'll see here the asymmetry of those incisors as well. But it's not a bad way. So it's pretty good result. Patient was chuffed. The patient actually wants to stop now. I'm like, no, it's not quite perfect yet. Let's just get that perfect and we'll be happy. So now if this was your starting position, Devkina, if this was your starting position, and let's say there was a space requirement to remove 0.5 millimeters, here I might then be happy to use a burr, and in my hands, I'm happy to do 0.3, 0.4 at the first day, and then just do a little bit as we go along. I know my principal, Richmond, he's very happy to do as much IPR as possible where the contacts are already straight. What are your thoughts on that?
I always think it's better to be conservative with your IPR. After you've taken away that enamel, you're not getting it back. And you also have to think about the aesthetics. What's it going to look like? If they're going to look like tombstones, it's not going to be nice for the patient. So I prefer not to do all my IPR at one go. I like to stage it, because teeth are continually moving and you need to forward think, where are my teeth wanting to go, and then do the IPR to facilitate and create space for them to move, if that makes sense. If you do it all at the beginning, you could lose space, and space is at a premium, so especially with IPR, so you want to be really, really careful.
I'm happy and I respect that, because that's the beauty of dentistry. Everyone's got different opinions and different ways to do it. So you're in the camp that you like to do it sequentially. I am quite case selective. Some cases I'll do it sequentially. Other cases where I have to admit, if I've got a beautiful straight contact, then I may be happy to do a bit more. But I see your point about them looking like tombstones. I think in clear aligners, you get away with it more than in fixed appliance.
Yeah. Well, to be honest, in fixed, normally we wait until the teeth are aligned and then carry out our IPR. So it's a little bit different. And there shouldn't really be a difference, because whether you're doing fixed or Invisalign, you should plan and treat the same. But I also like to mention that it's really worth, when you're planning, that you consider your rotations, because I always correct my rotations first before any IPR, because you always will gain space from derotating teeth. Otherwise, you might be left with too much space at the end, and you then have to close.
That's fair. That
makes sense. Yeah,
it does. I'm just trying to visualize that. So an upper central incisor. If an upper central incisor is rotating, it will usually require space, right?
Yes. Sorry. What I mean by that is your premolars and your posterior teeth. So
Sure.
yeah, sorry, that's confusing. Posterior rotated teeth will give you space. Anterior rotated teeth are crowding.
Yep.
They need space. Yeah.
So and just leading on from that, in those scenarios where you've got those barrel shape or parallel contacts and you want to avoid IPR, then maybe in those cases, if it's still a mild case, you should be looking towards expansion, arch development. Is that how you're looking to achieve your space?
Yeah, so if you're going the non-extraction route, you want to be thinking about things like expansion. Now, we know that expansion is a great way to achieve space creation, but it's also can be quite inherently unstable, especially in the lower arch. You don't really want to be expanding the lower canine to canine. So there's lots of studies on that from Little and others about how you've got a higher risk of relapse if you expand the lower intercanine width. So you want to keep that the same, but then you can expand more on the premolar or molar region.
I think there was one about how IPR can actually improve your stability. Do you want to just touch on that?
Yeah. So there has been research to show that IPR can even help stability post-treatment. Peck and Peck suggested that if you have parallel edges, then there's less chance of contact slippage. So in theory, your teeth should remain and stable after treatment. And I can, even if you're using common sense, that makes sense, right? I mean, if you've got parallel teeth.
If you've got more contact surface area, it just, there's less chance for them to come away.
Yeah, so IPR has even been used as a reason to achieve stability in cases like that as well. Okay, so here is a patient who had quite significant crowding. You can see that she probably has about 5 millimeters of crowding, and it's displayed in the anterior region, but because it is quite significant, it's also extended up to where the premolars are. So I actually did 2 plans for her. I did a plan where we did a lot of IPR and an extraction of a lower central incisor. She didn't want an extraction at all, so hence we're going with this plan. But we can see, if I'm just taking it through, there's a lot of IPR at the beginning, but just because it says 0.3, I might not do the whole 0.3 right at the beginning. But I will always make a note of how much I've done. And I think medico-legally, that's really important as well.
Yeah, it's gold standard.
Yeah. So I use my gauge. I even up the contacts. The teeth will then start to move. And you can see that it's been planned so that as the teeth need it, the IPR is taking place when it's highlighted in yellow. So
and you're using the Devaki approach of sequential stripping as you go along?
Yeah, exactly.
Any deviation in this case, for example, that lower left premolar and molar, if you just go back to when it was a bit crowded? So yeah, tell us between the 2 premolars. So that's a tricky one, because if you start, if I was to start stripping the mesial surface of that lower left second premolar, then actually that would be the buccal. That would eventually be the buccal surface, right? If I just put a strip there, imagine I put a double-sided strip there between the lower left 4 and 5. You're actually removing it from the buccal. That's not where the contact is. So in that case, I'd be more inclined to get my soft flex disc out and actually disc the mesial surface. Is there a better way to do it than that? Is there a different way?
Yeah, so alternatively, you could use a really fine non-cutting burr. And the burr I would like to use, and I will only use burrs posteriorly. So anteriorly, I'll just use the strips only because I have more control. I can protect my soft tissues with cotton wool rolls. You can also use suction to protect your soft tissues. But posteriorly, I'll use, if I need to take a significant amount away, I'll use the burr. And the burr I use is... they're the strips. This is the burr.
Yep.
So this is from Top Dental, but you can get these from various other suppliers. It's non-cutting at the bottom, and the diameter of this is 0.3 to 0.4. So it's giving you the amount that you want posteriorly. Some other flame-shaped burrs are more than that. That's why I don't like to use them, and I have less control. Whereas here, I mean, he's using this anteriorly, but I would use it posteriorly.
Yep. Let's just hover your mouse over that photo again, the way that this clinician is using it. Now, there's no right or wrong, because that is what works in your hands and your experience. So let's just start with that. There's no right or wrong. Now, some people, and I've seen some videos back when I was had my first IPR case coming up some years ago, and I was looking at, okay, how am I do IPR? And I was watching all these videos and stuff, and asking different clinicians. And some would say, hold the burr like this and go up and down, okay? Whereas others would say, no. If you do that and you slightly deviate, you make a nasty shape, a nicely little ditch in the tooth.
A ledge,
a negative ledge in that way. So then the other way to do it would be hold it like so, vertically, and then just do like little brush strokes, which is what I do most 99% of the time. That's what I'm doing. Do you have a preference? Because obviously you're doing it posteriorly. So, I mean, going near the gingiva and going up, for me, it's that angle, it doesn't make sense to me as much.
Yeah, I mean, I'd have to agree with you there. I prefer to go parallel to the tooth rather than perpendicular with a burr.
Yeah, but if you can get the right access, I'm not saying it's the wrong thing to do, but if you can get the right access, if you're very experienced at doing it, just be very careful, use higher magnification, it would be my opinion.
Yeah, I completely agree. I mean, going incisally, going downwards, parallel to the tooth, just enables me to remove more tooth tissue where I need it, where it's where there's more incisally. I don't really want to remove as much gingivally. And although it's a non-cutting burr, I'm just trying to think about where I want to remove.
What do you mean by a non-cutting?
So these burrs, they're non-cutting at the tip.
At the tip, yeah.
Yeah. So
brilliant.
Yeah.
Strips. So is there any technique to hold it? For example, I've seen some clinicians go really, really fast, and that's the way to do it. Others put a lot of sustained pressure. Any tips you can give us? Is there a wrong way to do it in certain holding it, whatnot?
I think, I don't know if there is particularly a wrong way. The way I do it is I do it pretty much like in this image. I'll bring it down and I will see it around the tooth, a bit like floss. And then I will do this.
Yep.
Like that, up and down, just to make sure that I've removed an equal amount. Now, some people criticize strips because they say they're time consuming, etc. But I feel like with the strips, you have the most control and it happens really slowly. So chances of any soft tissue trauma or anything like that are reduced, I feel.
Mm-hmm. I agree with you. I think these strips have been a constant source of repetitive strain injury for me. But it is a controlled way of doing it. But yeah, sometimes when you're doing like 0.3 or with the strips and you're really there and the patient's like, when's this going to end? So
yeah. But that's when I think you want to then go in with your disc or your file with the
as an adjunct. You don't have to just use one. You can mix and match. It's good.
Yeah, exactly. This is a good entry, and then you can follow on with those other ways.
Mm-hmm. Do you apply fluoride as a rule every time you do IPR?
So there are mixed views on this. There's some evidence to say it's good to reduce plaque formation and things like that, but other evidence to say it's unnecessary. I personally don't use fluoride unless someone is reporting that they get quite sensitive teeth to me beforehand. I don't use fluoride. I just recommend them a sensitive fluoride toothpaste for
I'm in the same camp as you. So I used to apply fluoride all the time until I looked at the evidence and suggested actually the saliva is going to do a good job of remineralizing it and you don't need it. And the other thing is that what message are you sending to the patient? If every time they're coming in and you're like, we have to apply the fluoride, don't eat for half an hour or whatever, they're thinking, oh, my enamel's getting weakened. They're having to do all this adjunctive stuff. So it sends the wrong message, I think. So exactly. I do it for sensitive patients, just like you.
Yeah, and even in the evidence, Zachrison did a 10-year follow-up study and people had very minimal risks associated with it. You know, there wasn't much sensitivity, no periodontal or caries risks associated with it. So I just think, you know, it's case dependent. Has the patient got good oral hygiene? Have they got healthy gums? If so, then
that's the most important thing.
Yeah.
Right. Cool. I'm going to check for any more questions. I think we've done really well. Devaki, you've pretty much answered all the questions I had. Is there anything that you think we want to cover to make it a really cutting edge resource, excuse the pun, for IPR for beginners?
I think the most important thing is planning. So it's really important to take the time at the beginning to assess how much crowding you have. Where is the crowding? Look at all your factors. What is my tooth shape like? What are the aesthetics like when the patient's smiling? How much tooth show do they display? I mean, a lot of this information you will get from your assessment. And then when you're planning, don't just follow what the ClinCheck's telling you. Although Invisalign plow billions of pounds into their system, and it's a really great system. I love Invisalign, but it is about the clinician planning the case. And that's one thing I think is really important. So think it through. You can tell Invisalign, I want IPR at this stage. And that will make you an even better clinician if you put your take on it, because you are the person planning the treatment. Invisalign is just a tool.
Brilliant. I love that. And one thing you just reminded me of is you mentioned earlier about whether you're doing fixed appliance or Invisalign, the movements and the stages of the movements are very similar, if not identical. So in fixed appliance, you're waiting for the contacts to become parallel, uncrowded, and then you're doing the IPR. Whereas when I've been on the Invisalign courses before, they're very scared about round tripping.
Yeah.
Can you explain why are Invisalign folk scared of round tripping? Where actually in fixed appliance we are round tripping a lot.
Okay, yeah. Well, I mean, my professors would kill me for this, but I mean, in theory, you should never round trip ever. I mean,
minimize round tripping, of course.
Yeah. Basically, in fixed, in theory, you shouldn't be round tripping either, because you should be cinching back your wires, controlling your AP arch length and things like that. So round tripping isn't a good idea, whatever you do, because you're proclining teeth, you're putting strain on the gingival tissues. You should also be considering if that patient's got thin gingival biotype. And again, this is where people just accept the ClinCheck, but they don't realize or may not take consideration into what are my patient's gingival tissues like? Can I just leave them changing their liners every week without monitoring that? So that's really, really important. But I completely understand what you're saying. With fixed treatment, you're in night eye wires, the teeth are tipping everywhere. I'm sure if we actually then put that on a ClinCheck, we would see a bit of forward back movement. But with Invisalign, the beautiful thing about it is you can digitally see where the teeth are going to go. So because of that foresight, you can plan for it not to happen. And that's why I love the superimposition tool, because I can say, and I specifically say to Invisalign, unless my teeth are retroclined and I can afford for them to come forward a little bit, I can say to Invisalign, do not procline the lower incisors.
Yep.
Yeah. And then if there's too much IPR, lower 3 to 3, I'll take it back to the premolars. Premolars are bulbous. You can afford to do that.
Perfect. Yeah. So I think that answers it well. So we want to ideally minimize round tripping where we can, and with the beauty of ClinCheck's virtual plans, we can stage our IPR in a way that it will have to mean less IPR, even though they're not fully aligned just yet. But you could, with the strips, I think it gives you that ability to take away a little bit per time. And I've just realized something that we didn't do is that we talked about round tripping, but there may be some young dentists out there who don't do any ortho, who are just listening in, and they're maybe thinking about starting ortho, and they have no idea what round tripping is. I didn't know what round tripping was when I was an undergraduate. Maybe you did, because ortho was your passion area. Can you just explain round tripping?
Yeah. So round tripping is basically, as the teeth align, there's a tendency for the lower incisors or even the upper incisors to procline. That is called tipping. And in ortho, you want to torque the teeth to enable the roots to be in a stable position. So then what ends up happening is, after your naito wires, for example, you go into more rigid wires and the teeth end up coming back, because you're then torquing them, because you're moving the roots in the right position. I don't know if that's a good explanation.
No, it's fine. So it's coming forward and then coming back again. You're going around again. And the
then you're straining the gums.
The straining, exactly. I was going to comment. So why is it round tripping bad? Is gingival, the supporting structures maybe taking a bit of a beating?
Exactly. And you always want to move teeth in bone. So if they're just proclining, there's a risk of you God forbid this would ever happen, but perforating the cortical plate, etc.
And getting these gingival recession areas and whatnot.
Dehiscence and that sort of thing. And this is another really important tip, is if you do notice any recession in your assessment, it's really worth noting it and measuring it and documenting it, because sometimes the recession can get worse as the teeth align. So
that's a really good point. I think our photos help us, but it's medically legally really good to measure it with a perio probe or something, because every orthodontic patient I've ever had who had significant or moderate to significant recession to start with, but they were periodontally healthy and we've chosen to do orthodontics, you know what they all say? They all email me, especially during lockdown period. I'm emailing, I'm checking in my patients, and they all say, you know what, I feel like my recessions got worse. In fact, some of my whitening patients, okay, I just give them whitening trays, which are nowhere near the recession because I want to keep it away from the root surface area. Yeah. And they come back and say, oh yeah, my teeth are whiter, but I think the whitening caused my recession. But because it's just, they are more aware of the recession now. And some teeth are aligning there that you can see the areas where you couldn't see before. So a lot of the times patients are thinking, oh my God, my recession's gone worse or whatever, but really it's probably not happened. But if it has, you need to make sure you're on top of it, and that's where your documentation comes in.
Yeah, I completely agree. And 9 out of 10 patients, they'll come in saying, I don't like this. And like you said, as the teeth are straightening, they spend so long looking at their teeth, they'll find other things they don't like. So it's just always worth gathering this information at the beginning, as much as you can, so you can exceed their expectations rather than under-deliver.
That's a really good communication point there. So one thing, the way I like to do it, Devaki, is when they say their main complaint, and then I say to them, okay, and what else? Anything else? And then they might say something else. But if you didn't ask them that, they would have never said that second thing. And then you keep going. You keep asking them until they have nothing more to say. And then I sometimes tell my patient that, okay, the reason I'm pestering you is that although you're unhappy about this main thing here, I often find that when we sort that one main thing out, then you notice all the other myriad of things. So it's really important that you take a good objective look. Obviously subjective as well, because beauty is in the eye of the beholder, and orthodontics is essentially that. But it's a great communication point you raised there to have a chat with the patient in that way. So Devaki, thank you so much for coming on and helping us about IPR and getting the nuances and how to hold a burr and the different methods and a brief overview of the evidence. Really appreciate it.
It's been an absolute pleasure. Thank you for having me on here. I've really, really enjoyed it, and I hope people find it useful.
I'm sure they will. Thank you so much.
Thank you.
So I hope you enjoyed that chat with Devaki all about IPR. Thanks so much for listening all the way to the end. As always, I really appreciate it. If you'd like to suggest a topic, please get in touch. Follow the Facebook page, follow the Instagram page, and let me know how I'm doing. I want to put on some good topics. I'm enjoying myself. Look, I love podcasting. I love learning from my guests. So it's a hobby of mine. And if you find it's bringing value to you, then please share it with your friends and suggest some topics that I should cover. Thanks so much once again.